Good afternoon to everybody who's still awake. And so I want to talk a little bit about health systems issues. And as we'll talk about in a minute, we have concerns of for a lot of information during conflict, post-conflict, in displaced populations. We've talked a lot in this session about mortality data, the shortcomings, the challenges, the issues there. Morbidity data is something that we could spend a lot of time talking about. This is an area that's problematic because in many situations it's very hard, even through good surveillance systems, to track that. One of the areas that probably has gotten very little attention is function of the health systems, and looking at what can be measured in situations, how to measure this. What information that is often collected is related to outputs. How many people were seen, age groups, gender, and so forth issues. But very, very seldom are efforts made to try to look at the quality of services that are being provided and the completeness of services. And even less commonly is this done on a comprehensive basis where you're looking across a large number of facilities and so forth. So I'm going to talk a little bit about some of the work that we have done in Afghanistan, and then some of the issues on measurement of health systems in Iraq. We'll talk about some measurement methods. One of the things that we have to talk about in the health system is often we're unable to get a complete picture, as one might do in a large population survey, and one has to triangulate results from multiple sources, from multiple windows. So that's what I want to talk about. Now, first off, just not directly related to health systems, but I want to say a little bit about infant mortality, since we've talked about that, and since we were involved in some of the estimates for this in Afghanistan. So these are some pictures of best estimates for Afghanistan infant mortality in the pre-Soviet days. Now, Afghanistan is probably one of the few countries in the world that's never had a national census. And there was a try at one point, but the Soviets arrived to interrupt the process, so never quite got finished. And there have been discussions about census in the future, but so far, no national census. And so these represent best estimates from UNICEF and best estimates from other organizations. So this is what things look like in the, or estimated look like in the pre-Soviet days. And in the Soviet days, the trend tended to flatten off a bit, and even in the pre-Soviet days, these were days really before primary health care, some clinics and some facilities in the urban areas, very little in the rural areas. During the time of the Taliban and the Mujahideen, these patterns pretty well flattened off. And then in 2006, we did a rural mortality survey, 8,000 households in 29 of the 34 provinces, and we got a picture like this. Last year, the National Rural Vulnerability Assessment carried out similar assessments, and their numbers are not too far off of this as well. So this kind of represents basically what's happened, we believe, in the childhood and infant mortality in Afghanistan during the last few years. Now, these are rural populations, and this involves women 15 to 25. There's a lot of issues with this. This was not an easy study to carry out, and there are a lot of problems. There's a paper coming out on this shortly in the bulletin of WHO, which will detail all the difficulties people had about recalling ages and deaths and so forth in the infant and under 5 mortality study. But I want to talk now mainly about measuring the health system. And this is something we've been doing since 2004. We do this every year. And this comes from about 650 health facilities that we'll assess each year in 29 of the 34 provinces. And this year, well, starting in 2009, we're a bit slow this year. And we're getting to still a large number of facilities, probably 10% of the facilities in the 29 provinces are not accessible because of security issues. And we have looked initially at the primary healthcare facilities, and in the last couple of years we've added provincial and national hospitals to these assessments as well. And so this is just a little bit of information on some of the indicators. These are a large number of indicators, and we use a balanced scorecard approach which has proved to be very satisfactory, easy to understand, and easy to implement. These are the national means. So this is availability of drugs, and so this has improved substantially. These are the percentage of facilities meeting upper benchmarks and lower benchmarks. So gradually over the 5 years, there's been a substantial improvement in availability of drugs. Then we looked at functioning equipment, a list of basic functioning equipment. That also has increased substantially over the intervening period of time. So we've seen health facilities performing better in that way. And these are just a few out of probably 150 different indicators. One of the big concerns, of course, about Afghanistan is the high maternal mortality rates. There was a RAMO study about 4 years ago, I believe, and 5 years ago, and this year there's going to be a WHO national mortality survey, and the figures for Afghanistan have been probably about the highest in the solar system. And there's been a lot of concern about this, and the ministry feels that it's implementing programs that should have affected the maternal mortality, and so we'll see shortly. But some of the indicators we've had is looking at the capacity for safe delivery. Do the facilities actually have what's required on hand to provide safe deliveries? And you can see at the beginning of 2004, very little. In the area, which is not shown here, of obstetrical emergency, the capacity to address those, district hospitals, about 9% of district hospitals could do cesarean sections in 2004. And that figure is now up to 97%. So that's been a dramatic change. We've also, in the survey, looked at, an household survey, looked at the delivery with safe birth, with trained birth attendants, skilled birth attendants. That's increased from about, I think about 3% to probably about 30%. Still very low, but that's been a substantial change. So right along the line, these different levels for basic health centers, comprehensive health centers, and district hospitals have all shown a substantial improvement in their capacity to do safe deliveries. Then we look at staffing levels, and in 2004, compared to establishments, facilities were running about 40% of their establishment. It's now up to close to 80%. What's not shown on here is the percentage of female health workers, which has increased from about 5 or 6% to now close to 34, 35%. Now, many of these are in fairly low positions or not related directly to patient care. But one of the things which I've not shown on here is we looked at the quality of the consultation, basic kind of things that have to be done in any consultation. And it was interesting to find the best quality services occurred when the patient was female and the health provider was female. And once you started introducing males into the situation, either as recipients or as providers, quality went down. I won't go into further details on that, but you could work through some of those issues.